Hello everyone, welcome to my YouTube channel. This is Sir Steven, and today, as a part of developmental biology series, we will talk about the female physiology before pregnancy and the female hormones. Before we start, we should know that female reproductive functions can be divided into two major phases. First one is the preparation of the female body for conception and pregnancy, and the second is the period of pregnancy itself. This lesson is concerned with the preparation of the female body for pregnancy, and for the succeeding chapters and presentation, we will talk about the physiology of pregnancy and childbirth. Here, the learning objectives are as follows: review the sex differentiation in females, review the functional anatomy of the female reproductive tract, describe the hypothalamo-anterior pituitary regulation of ovarian function, describe the synthesis and regulation of secretion of estrogen and progesterone, enumerate the effects of estrogen and progesterone, review the events during the puberty, describe the hormonal regulation of the menstrual cycle and the changes during the ovarian and the uterine cycles, describe the hormonal changes and their effects on menopause, describe the events during the female sexual act and the different mechanisms for methods of contraceptives in females. Here is just a snippet of the internal and external parts of your reproductive female organs. Okay, we can see here the in number 34 we have there the mesovarium. We have your different arteries and veins. Okay, we also have the vulva, the labia majora, minora, and the clitoris. With number 9 is the vagina. You can see the 14 is the uterus, the 21 is the endometrium, we have the 30, which is the ovaries, and so on and so forth. So you should be familiarizing yourself with these different parts of your reproductive anatomy of your female sexual organs. During the fetal life, the outer surface of the ovary is covered with a germinal epithelium, which embryologically is derived from the epithelium of the germinal ridges. So when your female fetus will develop, the primordial ova will differentiate from the germinal epithelium and migrate into the substance of your ovarian cortex. You can see the photo on your left, a human fetus which is attached to the placenta at 3 months of gestational age. So your ovary again is covered with that germinal epithelium. Each ovum then collects around it a layer of spindle cells from the ovarian stroma, causing them to take on epithelioid characteristics, and then we further call them granulosa cells. The ovum is surrounded by a single layer of these granulosa cells, which is we called primordial follicle. And then we call this generally as a primary oocyte. Look at this, the female reproductive organs. You have the uterine tube, the ovary, the uterus, the cervix, the urinary bladder, which is not a part of the reproductive organ but it's included here, the vagina, urethra, the clitoris, labio majus, labio minus, and your anus. With the internal structures of the uterus, ovary, and the uterine tube, we have here the perimetrium, the uterine cavity, endometrium, myometrium, uterosacral ligaments, the cervical canals, the vagina, the vaginal rugae, cervix, the isthmus of uterus, broad ligament of the uterus, corpus luteum, ovarian follicles, ovarian vessels, fimbriae, mucosal folds of the uterine tube, and ovarian stroma and ligament, ampulla of the fallopian tube. Later on, we'll discuss what these anatomical parts are helping and playing role in preparation for pregnancy and the female hormones. We have here oogenesis and the follicle development on your ovary. This happens before birth, at birth, each month from puberty to menopause, which is happening every the menstrual cycle. Here with the ovulation, then the fertilization. Your primordial germ cell will underwent repeated cell divisions and then migrate to ovarian cortex. The oogonium will become, it's either the primary oocyte during birth, and then in follicle development in their ovary, this will be covered with the granulosa cells in becoming a primary follicle, will become a pre-ovulatory mature follicle, and release the ovulatory secondary oocyte, which will be met by the sperm. And after the meiosis 2 has been completed, only if fertilized, it will become the ovum or the zygote, and the second polar body will degenerate. On the other hand, once the pre-ovulatory follicle has released the ovulated secondary oocyte, it will become the corpus luteum. In your female hormonal system, we have different hormones that are acting upon it. The first one is the hypothalamic releasing hormone, the gonadotropic releasing hormone, the anterior pituitary sex hormone, the follicle stimulating hormone, and the luteinizing hormones, the ovarian hormones such as the estrogen and progesterone. During the female sexual cycle, the menstrual cycle, there are appropriate plasma concentrations of the gonadotropins and ovarian hormones during menstrual cycle. We have here the FSH and LH. So if you notice, the estradiol will be increased, okay, during before ovulation, and then it will decrease after ovulation and increase slightly right after the ovulation, and in comparison to the progesterone, which is the opposite effects, okay, the progesterone will just increase right after the ovulation phase. It will increase its number until 8 nanograms per ml. On the other hand, with the FSH and LH, both of them are increasing their volume in the ovulation phase, except for the FSH, which is will be a little bit higher as compared to the luteinizing hormone. Okay, and then afterwards they go back to their original volume after ovulation, with the FSH slightly increased than compared to LH. During the monthly ovarian cycle, we have the function of your gonadotrophic hormones, and we have two different significant results. Only a single ovum is normally released from the ovaries each month, so that normally only a single fetus will begin to grow at a time. The uterine endometrium is prepared in advance for implantation of your fertilized ovum at the required time of the month. Their effects on the ovaries: in the absence of LH and FSH, ovaries remain inactive. Normal monthly sexual cycles begin between the ages of 9 to 12, and this is called the puberty, and the time of the first menstrual cycle is called the menarche. Now we talk about the follicle growth in your ovaries, which is the follicular phase of your ovarian cycle. At birth, in the female child, each ovum is surrounded with the granulosa cells. The ovum with this granulose cell sheet is called the primordial follicle, and as throughout the childhood, the granulosa cells are believed to provide nourishment for the ovum and secrete an oocyte maturating inhibiting factor that keeps the ovum suspended in the primordial state this entire time. After puberty, when these FSH and LH from your APG begin to be secreted in significant quantities, then the ovaries, together with some of the follicles, with them begin to grow. The first stage of follicular growth is moderate enlargement of the ovum itself, so it needs to be doubling in size, which increases in diameter twofold or threefold. Then follows additional layers of granulosa cells in some of the follicles, and these are called the primary follicles. These are the stages of follicular growth in the ovary and following the formation of the corpus luteum. So you can see that there are layers of this, what we call as granulosa cells, are surrounding, okay, your ovum. Technically, these are just as it thickens in preparation to ovulation. You will see when it ruptures the egg, okay, with the corona radiata, this surrounding granulosa cells, or the pre-ovulatory follicles, will become the corpus luteum, and degenerating, becoming corpus albicans, and it will be released during menstruation. The antral and vesicular follicles in the first few days of the month, the LH and FSH level are increased with accelerated growth of 6 to 12 primary follicles each month. The initial effect is rapid proliferation of the granulosa cells, giving rise to many more, again, layers of this. In addition, spindle cells will derive from the volar endosteum collected in several layers outside the granulosa cells, giving rise to a second mass of cells. We call them the theca, which is divided into theca interna and theca externa. After the early proliferative phases of growth lasting for a few days, the mass of these granulosa cells secretes a follicular fluid that contains a lot of or high concentration of estrogen. Now, this antral and vesicular follicles will accumulating this fluid, which will cause the antrum to appear within the mass of your granulosa cells, and the early growth of the primary follicle up to the antral stage is stimulated mainly by FSH alone. Then, this accelerated growth occurs, leading to a larger called vesicular follicles. This accelerated growth is caused by, first, the estrogen being secreted into the follicle, causing the granulosa cells to form increasing numbers of FSH receptors. This causes a positive feedback effect because it makes the granulosa cells even more sensitive to the FSH from the anterior pituitary gland. The pituitary FSH and estrogens combine to promote LH receptors on the original granulosa cells, thus allowing LH stimulation of these cells to occur in addition to the FSH stimulation. So that's why when you see the graph earlier, both of them are increasing at the same point in time, thus increasing a still more rapid increase in follicular secretion. The increasing estrogens from the follicle plus the increasing LH from the anterior pituitary gland act together to cause proliferation of these thecal cells and increase their secretion as well. When full maturation each month of only one follicle, atresia of the remainder, some large amounts of the estrogen form the most rapidly growing follicle, acting on the hypothalamus to depress to further enhance the secretion of FSH by the anterior pituitary gland. In this way, they will block further regrowth of the less developed follicles. Now we talk about ovulation. Ovulation technically is occurring 14 days after the onset of menstruation. Shortly before ovulation, the protruding outer wall of the follicle swells rapidly in a small area in the center of the follicular capsule called the stigma, protrudes like a nipple. Later, fluid begins to ooze from the follicle through the stigma, and about 2 minutes later, the stigma ruptures widely, allowing more viscous fluid, which has occupied the central portion of the follicle, to evaginated outward. This viscous fluid carries with its ovum, surrounded by a mass of 1,000 small granulosa cells. We call them the corona radiata. There is a need for the LH to cause ovulation. That's why there is an ovulatory surge of LH. LH is again necessary for final follicular growth in ovulation. Without it, even when large quantities of FSH are available, the follicle will not progress to the stage of ovulation. Before the ovulation, both the FSH and the LH levels are being spiked. You will see here, following a surge of your LH, an oocyte immature egg cells will be made available to be fertilized by a male sperm at the end of the follicular phase of your ovarian cycle and a start of the luteal phase, which we will talk about later. They will act synergistically to cause rapid swelling of the follicle during the last few days before ovulation. LH will influence the granulose and theca cells into progesterone secreting cells. There is, first, rapid growth of the follicle, diminishing estrogen secretion after the prolonged phase of too much estrogen secretion, and beginning secretion of progesterone that ovulation occurs. When we start ovulation, there are two main events. First, the theca externa begins to release some of the proteolytic enzymes from lysosomes and will cause the dissolution of the follicular capsular wall and consequently weakening of the wall, resulting in further swelling of the entire follicle and the degeneration of the stigma. Simultaneously, there is a rapid growth of new blood vessels into the follicle wall, and at the same time, prostaglandins are being secreted into the follicular tissues. The combined follicle swelling and simultaneous degeneration of the stigma cause follicle rupture with the discharge of your ovum. And this is the postulated mechanism of ovulation. LH will be stimulating the follicular steroid hormones, which will categorize into two collagenase, the follicular hyperemia, prostaglandin secretion, and will cause them to follicle rupture and the evagination of your ovum. Now we'll talk with the luteal phase. After expulsion, the remaining granulosa and theca interna of the cells change into what we call as the lutein cells. The cell is not called the corpus luteum. The granulosa cells in the corpus luteum develop extensive intracellular smooth endoplasmic reticula that form large amounts of the female sex hormone progesterone and estrogen, but more so of progesterone. The theca cells form mainly the androgens, androstenedione, and the testosterone rather than female sex hormones. The corpus luteum begins to involute and eventually lose its function and becoming the corpus albicans. LH will stimulate the conversion of granulosa and theca interna cells into lutein cells. Corpus luteum was programmed to secrete progesterone and estrogen. Involution of the corpus luteum and onset of the next ovarian cycle, since estrogen has a very strong effect in inhibiting the secretion of FSH and LH. Luteal cells also secretes inhibiting, which inhibits FSH secretion. Drop in FSH and LH level, we can see earlier in the graph, will leads to involution, and before the start of menstruation, estrogen and progesterone inhibitory levels drop, which allows the FSH level and LH level to return to a being new cycle. Now we will talk about the functions of the ovarian hormones, estradiol and the progesterone. And here is the chemistry of these sex hormones. The estrogens are secreted by the ovaries. We have the beta estradiol, which is the principal. Large amounts of these estrogens are being released by the ovaries. The estrone, the estriol. These are mainly promoting proliferation and growth of some of the specific cells in the body, and these are responsible for most of your secondary sex characteristics of the female. Now, you can see here, this is the menstrual cycle. On average, by biological stage, intercycle variability and interwoman variability, because it doesn't happen. This menstrual cycle and the regulation of these hormones in the amount of volume and time is not the same for all, okay, for all humans. So you can see here the intercycle variability, average, and interwoman variability. Progestins, such as your progesterone, is concerned mostly for the prenatal preparation of the uterus for pregnancy and the breasts for lactation. And these are coming from the idea that the cholesterol will differentiate into pregnenolone and progesterone, releasing these different types, DHEA, androstenedione, and become testosterone. With the help of aromatase, they will become the estrone, E1, beta estradiol, E2, and estriol. Let's talk about the interaction of the follicular theca and granulosa cells for the production of the luteinizing hormone, producing androgens that diffuse into the granulosa cells. And in these mature follicles, the follicle stimulating hormone acts on the granulosa cells to stimulate the aromatase activity, which converts the androgens to estrogens, AC, adenylate cyclase, ATP adenosine triphosphate, the CAMP, the cyclic adenosine monophosphate, and your LDL, which is the low density lipoprotein. So these are the receptors in your theca cells and your granulosa cells, but with the help of your adenylate cyclase, ATP is being converted to CAMP, with cholesterol differentiating into pregnenolone, progesterone, androgens, passing through the capillaries or the extracellular fluid. These androgens will, with the help of aromatase, will become the estrogens. Okay, but aromatase is being uh, s- uh, stimulated, or the release will coming from the ATP becoming CAMP with the help of FSH. So this is just a cascade of events happening in the interaction of your follicular theca and the granulosa cells for this production of estrogens. With estrogens and progestins, they're all steroids. They're coming from cholesterol, and during synthesis, progesterone and the male sex hormone testosterone are mainly synthesized first. Then, during the follicular phase of the ovarian cycle, before this initial two hormones can leave the ovaries, almost all the testosterone and much of the progesterone are converted into estrogen by the granulosa cells. With their transport in blood, they are bound to albumin and some binding globulins. With their fate, um, the functions in the liver in your estrogen degradation, liver conjugates the estrogens to form glucuronides and sulfates. Most of them are being secreted in the bile, and diminished liver function increases the activity of the estrogens in the body. For progesterone, they will be degraded to other steroid that has no progesteronic effect. Major product is the pregnanidiol. These are the functions of your estrogens and their effects on the primary and secondary female sex characteristics. On the uterus and external female organs, the ovaries, fallopian tubes, uterus, and the vagina all increase several times in size. Although the external genitalia enlarge, the deposition of fat in the mons pubis and labia majora, and with the enlargement of the labia minora, so you will see that the vagina is kind of puffy. The external part of your reproductive organs are puffy. With estrogen changes the vaginal epithelium from cuboidal into stratified type, which is considerably more resistant to trauma and infection than in the prepubertal cuboidal cell epithelium. Infectional in children, such as gonorrheal vaginitis, can be cured with the administration of estrogen. Effects of your estrogens on the fallopian tubes, causing the glandular tissues of this lining to proliferate and causing the number of ciliated epithelial cells that line the fallopian tubes to increase. Then the activity of the cilia is being enhanced. You will see here on your right a cross section of a segment removed in the course of surgical tubal ligation. Their effects on breasts, with the development of the stromal tissues of the breasts, growth of an extensive ductal system, deposition of fat in the breasts, so you will see they do not complete the job of converting the breasts into milk producing organs. On the skeleton, cause increased osteoblastic activity in the bones, bone destruction, causes spur growth in height. They cause uniting of the epiphyses with the shafts of the long bones. The female eunuch, who is devoid of estrogen production, usually grows several inches taller than the normal mature female because her epiphyses do not unite at the normal early time. With osteoporosis of the bone caused by the estrogen deficiency in old age, estrogen deficiency leads to diminished osteoblastic activity in the bones, decreased bone matrix, decreased deposition of bone calcium and phosphate. With their protein deposition, it will cause a slight increase in total body protein due to growth promoting effect of your estrogen. On metabolism and fat deposition, increased whole body metabolic rate slightly, also causing deposition of increased quantities of fat in the subcutaneous tissues, causing deposition of fat in the breasts, thigh, and butt. On hair distribution, it doesn't really have an effect, mainly due to androgens formed by the female adrenal glands. On your skin, causing a skin to a texture which is soft and usually smooth, causing a skin to become more vascular. On electrolyte balance, it causes the sodium and water retention by the kidney tubules. Now we talk about progesterone and its functions and their effects on the primary and secondary female sex characteristics. On the uterus, they promote secretory changes in the uterine endometrium during the latter half of the monthly female sexual cycle. It also decreases the frequency and the intensity of uterine contraction, helping to prevent expulsion of the implanted. So you will see here a micrograph showing changes in the endometrium during the progesterone production or the decidualization using a eosin and H&E stain. On the fallopian tubes, it promotes increased secretion by the mucosal lining of the fallopian tubes. On the breasts, it promotes development of the lobules and alveoli of the breasts. You will see, causing the alveolar cells to proliferate, enlarge, and become secretory in nature. With monthly endometrial cycle and menstruation, it proliferates the uterine endometrium, development of some of the secretory changes in the endometrium, and the desquamation of the endometrium, which is known as your menstruation. And just a quick review of what we had discussed. Now we will be moving forward with the proliferative phase or the estrogen phase of the endometrial cycle, which is occurring before ovulation. During the proliferative phase of this EC before ovulation, after menstruation, only a thin layer of the endometrial stroma will remain, and only the epithelial cells that are left are those located in the remaining deeper portion of the glands and crypts of the endometrium. With the influence of the estrogens secreted in increasing quantities by the ovary during the first part of the monthly ovarian cycle, the stromal cells and the epithelial cells will proliferate rapidly. The endometrial surface is epithelialized within 4 to 7 days after the beginning of menstruation, and during the next week and a half of the endometrium increases greatly in thickness owing to increasing in numbers of the stromal cells and to progressive growth of the endometrial glands and some of the new blood vessels into the endometrium. At the time of ovulation, the endometrium is 3 to 5 millimeter thick. Now with the secretory phase or the progestational phase of the endometrial cycle occurring after the ovulation, there is an increase of progesterone and estrogen levels after ovulation. The estrogen will cause a slight additional cellular proliferation in the endometrium during this phase of the endometrial cycle, whereas your progesterone will cause a marked swelling and secretory development of the endometrium. The glands increase in tortuosity, and an increase of secretory subunits accumulates in the glandular epithelium cells. Also, the cytoplasm of the stromal cells increases, lipid and glycogen deposits increase greatly in the stromal cells, and the blood supply to the endometrium further increases in proportion to the developing secretory activity, with your blood vessels becoming highly tortuous. This provides large amounts of stored nutrients to provide appropriate conditions for implantation of your fertilized ovum. Now, prior to that, these are just a snippet of the photographs coming from the celebration of the menstrual month or menstrual cycle month in India. That they were celebrating womanhood, celebrating menstruation, because in India, they see women when they menstruate as something that they should not be socializing. Okay, the women is restricted when they are menstruating. Okay, they're restricted in social activities and some of that. This is discharging blood and other material from the lining of the uterus, menstruation. If ovum is not fertilized, the corpus luteum in the ovary suddenly involutes and the ovarian hormones, estrogens and progesterone decreases to low levels and the menstruation will follow. During 24 hours preceding the onset of menstruation, the tertuous blood vessels leading to the mucosal layers of the endometrium become vasoplastic, presumably because of some effect of your involution and the release of the vasoconstrictor material, possibly one of the vasoconstrictor types of your prostaglandins and being present in abundance at that time. The vasospasm, the decrease of nutrients to the endometrium, and the loss of hormonal stimulation causing beginning necrosis in the endometrium, especially of those of the blood vessels. As a result, at first, it seeps into the vascular layer of the endometrium and the hemorrhagic areas grow rapidly over a period of 24 to 36 hours. Gradually, the necrotic outer layers of the endometrium separate from the uterus at the sites of the hemorrhages until about 48 hours after the onset of menstruation. All of the superficial layers of the endometrium have desquamated. The menstrual fluid is normally non-clotting because a fibrinolysin is released along with the necrotic endometrial material. If excessive bleeding will happen from the uterine surface, the quantity of fibrinolysin may not be sufficient to prevent clotting. Within 4 to 7 days after the menstruation will start, the loss of blood will cease because by this time the endometrium has become re-epithelialized. Okay? So you will see here the phases of your endometrial growth and menstruation during each monthly female sexual cycle: the menstrual phase, the proliferative phase, and the secretory phase. Along with that, your ovarian cycle will have follicular phase, ovulation phase, and your luteal phase. There is what we call as leukorrhea during menstruation. This may be due to the loss of too much of the blood. Leukorrhea is thick, whitish, yellowish, or greenish vaginal discharge. Menstruation is being regulated between an interplay of your ovarian and hypothalamic pituitary hormone. The hypothalamus secreted GnRH, causing the anterior pituitary glands again to secrete the LH and FSH. With intermittent pulsatile secretion of GnRH by the hypothalamus and pulsatile release of LH from the anterior pituitary gland, when that GnRH is infused constantly, then it will not stimulate the secretion of LH and FSH. So generally, if there is an intermittent secretion of the GnRH, okay, by the hypothalamus, there will also be a pulsatile release of LH from your anterior pituitary gland. The hypothalamic centers for release of your GnRH with the arcuate nuclei control most of your female sexual activity. This is a feedback regulation of the hypothalamic pituitary ovarian axis in females, with stimulatory effects are shown by plus signs, okay? And negative feedback inhibitory effects are shown by minus signs. Now, estrogens and progestins exert negative and positive feedback effects on the interior pituitary and hypothalamus. Depending on the stage of the ovarian cycle, inhibin has a negative feedback effect on the anterior pituitary, whereas activin has the opposite effect, stimulating hormone secretion by the anterior pituitary. We have CNS, central nervous system, GnRH, gonadotropin releasing hormone, and DLH as the luteinizing hormones. So they have like behavioral effects, okay? With the positive feedback effect and the negative feedback effect, all of these are tightly regulated in your CNS, of course. And ovulatory cycles, which is the sexual cycles at puberty. If pre-ovulatory surge of LH is not sufficient magnitude, ovulation will not happen. The cyclical variation of the sexual cycle will continue, but they are altered. First, there is lack of ovulation, which causes a failure of development of the corpus luteum, and there is almost no secretion of progesterone during the latter portion of the cycle. The cycle is shortened by several days, but the rhythm continues. These are the total rates of secretion of your gonadotrophic hormones throughout the sexual lives of the female and male human beings, showing here an especially abrupt increase of your gonadotrophic hormones at menopause in the female. With estrogen secretion throughout the sexual life of the pubertal female human being, so you have puberty, and then during the menopause, it slightly decreases in size. So this is like the bone mineral density, especially of the vertebra, which is decreasing with menopause. Okay, so osteoporosis, menopause, or what we call as the climacteric. At the age 40 to 50, the sexual cycles usually become irregular and ovulation fails to occur during many of the cycles. It is just simply burning out of the ovaries. Loss of estrogen causes hot flushes, psychic sensation of dyspnea, irritability, fatigue, anxiety, occasionally various psychotic states, and decreased strength and calcification of bones throughout the body. There are also abnormalities of secretion by the ovaries, such as in hypogonadism due to poorly performed ovaries, lack of ovaries, or genetically abnormal ovaries. Female eunuch is taller, and menses irregulation and amenorrhea is being caused by hypogonadism. It may also cause amenorrhea and leading to failure of ovulation. Hypersecretion in the ovaries may be due to a tumor. Now, with the female sexual act, it's stimulated at desired peak time of ovulation. Massage and other type of stimulation of the vulva, vagina, and other perineal regions can create sexual sensations. The glands of the clitoris is especially sensitive for initiating sexual sensations. With female erection and lubrication, it will be locating around the introitus and extending into the clitoris is erectile tissue. You will see here with the control by the parasympathetic nerve formed from the sacral plexus, with all of these signals passing to the bilateral Bartholin's glands, which causing them to secrete mucus, which is responsible for much of the lubricating during the sexual intercourse. Female orgasm is also helping to promote the fertilization of the ovum. During the orgasm, the perineal muscles of the female contract rhythmically, which results from the spinal cord reflexes, similar to those that cause ejaculation in the male. It is possible that these reflexes increase uterine and fallopian tube motility during the orgasm, thus helping us transporting the sperm upward the uterus toward the ovum, and may due to an increase in oxytocin secretion. Female fertility is the fertile period of each of the sexual cycle, and for the fertilization to take place, intercourse must occur sometime between 4 to 5 days before ovulation up to a few hours after ovulation. Rhythmic method of contraception is usually stated that avoidance of intercourse for 4 days before the calculated day of ovulation and 3 days afterward prevents conception. Hormonal suppression of fertility, or the pills, with this administration of either estrogen or progesterone will help LH secretion, thus preventing ovulation. Now, temperature, okay, slightly elevated shortly after the ovulation. These are some of the abnormal conditions that causes female sterility. Most common cause is failure to ovulate. Uses progesterone, its presence to determine if the female ovulate or not. It can be treated with the HCGs, also with endometriosis. The endometrial tissue is almost identical to that of the normal uterine endometrium that grows and even menstruate in the pelvic cavity surrounding the uterus, fallopian tubes, and your ovaries. It causes fibrosis throughout the pelvis, and fibrosis prevent the ovaries from being released. Salpingitis inflammation of the fallopian tubes, and lastly, secretion of your abnormal mucus by the uterine cervix. So I hope you've learned something for today. And in our next topic, we'll talk about pregnancy and lactation. This is Sir Steven, and thank you so much once again. Have a nice day, and goodbye.